Anterior vitrectomy is the very first step for any vitrectomy procedure. Achieving a good anterior vitrectomy is the prerequisite for a successful vitrectomy procedure. However, incomplete anterior vitrectomy often leads to primary posterior capsular opacifications, probably resulting from the metamorphosis of residual hyalocytes in the anterior vitreous layer. Too much anterior vitrectomy can lead to intraoperative lens opacification by inadvertently touching the posterior lens capsule by cutter tip, which can seriously hinder the visibility of the posterior pole. This often warrants removal of the crystalline lens by pars plana lensectomy. We introduce a safe and effective way of removing the anterior vitreous without the possibility of intraoperative lens touch. In our procedure, the surgeon has to perform anterior vitrectomy as much as possible, leaving a layer of anterior vitreous. Then proceed to the usual procedure of core vitrectomy. After this, we take the help of bubble-assisted anterior vitrectomy to clear up the leftover anterior vitreous safely. We take a 1 ml tuberculin syringe for this procedure and fill it with 0.1 ml of BSS solution. Then pull the plunger back to allow another 0.1 ml of air into the syringe. By holding the syringe in the needle down position, give the syringe a gentle tap so that the air bubble moves towards the plunger and saline moves towards the needle end. Ask the assistant to turn off the infusion line. Through one of the sclerotomy ports, push the saline and air mixture briskly with the needle pointing toward the center of the globe. This maneuver breaks the saline air mixture into numerous tiny air bubbles, which in turn rise and stick to the anterior vitreous layer. These bubbles appear to stain the anterior vitreous and also help to create a potential space between the posterior capsule and anterior vitreous face. With direct visualization, the anterior vitreous can be cut with the vitreous cutter under standard setting. As the surgeon cuts the bubble-stained anterior vitreous, the vitreous strands can be seen moving, which confirms adequate clearance of the vitreous layer without the fear of lens touch. Let us look at the bubble-assisted anterior vitrectomy with another example. This maneuver not only helpful in reducing the intraoperative lens touch and primary PCO formation, but also helpful in training new residents and fellows a safe way of anterior vitrectomy.